Now you got to stop.
Stop now.
Okay.
You're on the
So,
record.
yeah. So, and we introduced, and Matt, actually, you don't know Stevie, but we could do this later. He's the guy who's handling the questions, is
Okay.
Stevie Ray, and Chen is handling all the other things that we can't all handle ourselves. And I get to do the introduction, then get to sit back and listen to your brilliance. Welcome everyone to the first of this semester, Daniel's Fund in Professional Ethics lecture. I already wanted to remember that Chen talked about in a couple of weeks we're going to have another one, so put that on your schedule and your calendar. We do need to thank the Daniels Fund, of course, and the Division of Liberal Arts and Social Sciences. Liberal arts, that's old school. We are thrilled to have Dr. Wynia with us tonight. We've already talked a little bit about the technology, so if you have questions, please put them up as we go along and don't wait till the end, because I'm afraid we won't get to them. Dr. Wynia gave a lecture here at Mines, I don't know how many years ago it was now. It was and it was great.
Pre-COVID.
For sure, pre-COVID.
Pre-COVID, so.
Pre.
Yeah.
And,
years ago.
Yeah, it was. And it was great. Students loved it. I loved it. And I know students at Mines in general are really interested in bioethics. And now, of course, we are all interested, for better or worse, more attuned to ethical issues in healthcare. So asking Dr. Wynia back seemed like a completely easy thing to do, and we're really lucky that he can join us this evening. He is the director of the Center for Bioethics and the Humanities at the Anschutz Medical Center at the University of Colorado. He earned his MD at Oregon University and also holds a master's degree in public health from Harvard. He has had an interesting and wonderful career, including developing research institute and training programs focusing on bioethics, professionalism, and policy. He founded the American Medical Association Center for Patient Safety. He has led projects on a wide variety of topics related to ethics and professionalism, including public health and disaster ethics, medicine and the Holocaust, and inequities in health and healthcare. So he has written a lot of really cool things. He's been a guest on the BBC, ABC News, National Public Radio, among others, and we get to have him at Little Old Mines this evening. So we are indeed fortunate to have him with us tonight. And with that, I'm going to turn the program over to him.
Thank you, Sandy. And it's a pleasure to be here tonight. I apologize. Oh, you know what? It looks like host has disabled participant screen sharing. Can you let me share my screen? So I'll just get started without sharing the screen by saying that I'm gonna speak tonight a little bit about the ethical issues that arise in pandemics. And believe it or not, there are a group of us who have been thinking and writing about this for decades. There have been a series of pandemic lights, or almost pandemics, that have arisen since I first got interested in this area. I'm an infectious disease specialist, and so back in 2001, after 9/11, some of you will recall there were anthrax attacks on a series of installations and individuals around the country. And that really raised the profile of the idea of a bioterror attack. And there's some sort of sets of considerations that are very comparable when you think about bioterror attacks and when you think about naturally occurring infectious diseases. And so I started doing research actually on how doctors and patients think about some of the ethical issues in epidemics or outbreaks or under attacks, under sort of catastrophic disaster circumstances back in 2001. And then in 2004, I went to Indonesia after the tsunami. So there was an enormous tsunami. Thank you, Kin. There was an enormous tsunami. Hundreds of thousands of people were killed, and there were a bunch of, many people who went there. But some of my experiences there also ended up informing the way I think about this. So I'm now going to actually share my screen. Are you able to see that? Yes? All right. So I break the the sort of ethical issues in pandemics into three categories. And there's really a fourth R here, which could be research, because there are a number of research ethics issues. But I'm going to leave those to the side today and speak mostly about issues of restrictions on personal liberty and when is it okay for the state, for public health departments to tell people that that they have to stay home, that they can't go to work, that classes are going to be canceled, right? Those kinds of things, which are all infringements on personal liberties. And what makes it acceptable or unacceptable for the state to do those things. Rationing dilemmas, which are resource allocation issues when scarcity arises, so triage essentially. And responsibilities, what do we owe each other? Who has to continue to go to work even though it becomes more dangerous to go to work, that kind of thing. So those are sort of the three R's that I call of pandemic ethics. So normally, I have a poll here, but I'm actually not going to do it. Sandy knows I love polls. I'm actually not going to do these polls. I just want to show them to you and tell you what, because I've been doing this talk I've done this talk a number of times in the last couple of weeks. So I can already tell you what the answers are to these, which is this question has actually been asked repeatedly by pollsters since April. Actually late March, early April. And it has been remarkably the same all the way through. It's about 80 or 90% of people say that even though there's tremendous economic consequence to doing so, we really care about the well-being of our neighbors. And by the way, this has stayed true even as it has become more clear that by and large, young people tend to do pretty well with this disease. They get over it most of the time. But those young people have grandparents, and they know other young people who have significant illnesses and preconditions that might make them more likely to have a bad outcome. And so this has been very consistent. It also is a false dichotomy. And I think we just should acknowledge that, right? That the most frustrating aspect of the pandemic to date is the fact that we shut everything down back in March and April. There was tremendous economic sacrifice in order to buy time so that we would be ready and that we could handle this when the next little surges came. And unfortunately, despite that, we were not able to get prepared. And our country has really mismanaged this pandemic in some quite astonishing ways, because slowing the pandemic is, of course, what allows for the economy to come back. Because even if you open bars and restaurants right now, for the most part, people aren't willing to go to bars and restaurants because they're afraid that they're going to catch it while they're there. So this is a false dichotomy, but when you force people to make a choice, for 6 months now, it's been the same. About 90% of people say that slowing the pandemic is a priority, and then addressing the economic decline. I don't know if you guys do this all the time, but medical people do this all the time. I have to put a disclosure slide in for continuing medical education credit. So I'll just tell you, I don't have commercial relationships, but I have been involved in these 2 consensus studies in the last couple of years, both of which I'm going to mention. I'm not speaking for these committees, but these are both committees of the National Academy of Science, Engineering, and Medicine. One of them is looking at was looking at how to count people who die or are injured in catastrophic disasters. And the other is looking at the evidence base for public health emergency preparedness and response. So I'll refer to these a couple more times. So here's what we're going to do. I'm going to use a couple historical examples because I think they're interesting and provocative and I'm going to weave into those examples these 3 archetypal sort of issues of ethics in pandemics: restrictions on liberty, resource allocation, and responsibilities. And along the way, I'm going to talk about a few guiding values that are very commonly discussed when talking about pandemic ethics. So let me start with this. This is a little bit of an historical thing here, but there was a pandemic that swept across Europe in the 1200s. And this pandemic causes people to develop anesthetic patches on their skin. So areas of skin that you can't feel. They become insensitive to pain. As a consequence, they could become infected. They could get a cut or a bruise or something there. It could become infected. They wouldn't notice it. And the infection would get out of hand. And the next thing you know, you have to amputate. And so people ended up with amputations, the loss of limbs. This disease also causes collapse of the bridge of the nose, and the bacilli of this disease build up under the skin in areas of the skin that are cooler, which means the face, the nose, the ears, the lips, the chin. This creates what's called a leonine face or a lion-like face. So if you haven't recognized this so far, this is what happened to people who had this illness, is they were stigmatized and they were placed in colonies. So this is the leprosaria, the colony at Molokai in Kalapapa. And these people were essentially shunned by the rest of the community because of the illness that they had. And this is something where every time there's a pandemic, you will see something similar to this, where people bringing it to the country are sort of shunned, and it gets the stigma of being labeled as someone who is unclean is something. And also something unique and interesting about the COVID pandemic is that it has tended to be the wealthy people who bring the illness into a community. And then it's the poor people who suffer the most from it. So I don't know how many of you followed this story, but this article in the LA Times discussed how the coronavirus got to Mexico City. And the answer is it was wealthy visitors to Vail, Colorado, who came to Vail to come skiing, caught the coronavirus on the ski slopes and in the restaurants and the bars, and then went back to Mexico City. And of course, that's not where it stayed. Same in Los Angeles, by the way. I spoke to a reporter at the LA Times who said the first cases in LA were actually in the Hollywood Hills. Because of course, those are the people who are wealthy and can fly off to China and all over the world, to Europe, and then they bring it home. But of course, it doesn't stay in those wealthy neighborhoods. The housekeepers pick it up, the gardeners pick it up, and they take it back to the more crowded living spaces, to people who can't shelter in place, who can't stay home. And hence we see these enormous disparities now in the impacts of COVID-19 on underserved, under-resourced communities and populations. But this is a common thing throughout pandemics. And you'll see I'm not using the pandemics you think I'm going to use. I'm not going to use 1918. I'm not going to say much about even the 2009 pandemic. The Great Pox, if I had a live classroom, I would ask if anyone knows what the Great Pox was. So this is the opposite of the smallpox, was the Great Pox. Great Pox was syphilis. So in its early incarnation, when it first was, most people believe, brought back from the New World into the so-called Old World to Spain by Columbus and his crew, syphilis was a very aggressive illness. And in its secondary stage, it caused enormous boils full of pus. And it was very painful and often deadly in its secondary stage. And what happened is it spread throughout Europe. And as it spread, every country would blame it on some other country. So the Italians called it the Spanish pox, and the French called it the Neapolitan pox, and the English called it the French pox, and the Poles called it the German pox, and the Russians called it the Polish pox. So you can see the way, you know, the idea of the China virus is not unheard of. This is something that happens in pandemics where people sort of want to blame it on someone else. Similar to Hansen's disease or leprosy, Scottish patients with syphilis were sent to be isolated on an island. And also similar to subsequent pandemics, HIV in particular, there was a so-called medical controversy over whether doctors were right to treat people with syphilis, because after all, they picked it up doing something immoral and licentious. And as a consequence, they deserved what they were getting. And so this was largely a religious driven controversy over whether it was right for doctors to interfere in God's plan of punishment for people who deserved the illness that they were suffering. when you have fear and you have blame and you have stigma, you also have self-protective desires, right? People start to do whatever they can to take care of themselves. This is a very famous illustration. There are a number of others similar, called the doctor's robe. And many of you will probably recognize this image. It was a vestment and a face mask that was used to try and prevent catching the plague. So the plague, Yersinia pestis, was much, much more deadly than what we're seeing today. It was not unusual for 25% of the population to die in just a few days or weeks. It was said that people would sup with their kinfolk, sup with their family in the morning and dine with their ancestors in the afternoon. It was so fast that people could come down with the plague and die. And doctors, priests, others who tended to the ill would wear this garment in order to try to protect themselves. The beak would be full of straw and pungent aromas, so you could put spices in there. Sometimes people would soak a piece of fabric in like cat urine, something very smelly, and put it in there. The idea being, of course, that they thought that you caught plague from the ether, from the vapors in the room, and so you were trying to prevent the vapors from the room from getting into you. And the garment would be dipped in wax. So it was hot and sticky and heavy. It would be muslin dipped in wax. And this priest in Italy said it was very uncomfortable and moreover useless against the plague. The only thing it did was prevent fleas from getting on you. Which again, if I had a live audience, some of you would be chuckling right now because of course plague is transmitted by fleas. So this garment may have actually been protective, albeit not for the reasons people thought. So this question of masks raises the issue of restrictions on liberties, and I'm gonna circle back around to this a couple of times, but I want to sort of transition from taking care of yourself to enforcing things on others in order to protect yourself. And this is where I think we end up getting into these arguments, which have sadly in the US turned into sort of red-blue political arguments about, you know, does the state have the right to tell people to stay home, or does the state have the right to tell people that they ought to wear a mask? And this is, again, not a brand new argument. Back in the 1980s, there were a series of sort of dictators, mostly in developing world countries, who used ostensible public health threats to implement lockdowns and civil restrictions. And a group of lawyers at the United Nations got together and said, you know, we need some principles that will guide restrictions on liberties in service to public health. And they came up with this guidance, which is that if you're going to coerce people to do something, it needs to be a legitimate, well-researched public health measure. It has to be done legally, so there needs to be due process so that people can appeal what's going on. It needs to be necessary and non-discriminatory, and the necessary was really framed as the least restrictive means possible to achieve the public health goal. This, by the way, is very similar to the American framework, right? The American constitutional framework, the Fifth Amendment to the Constitution, the 14th Amendment to the Constitution, guarantee civil liberties and due process. And they say that the state has to have a legitimate, a compelling state interest, and the least restrictive means. That's actually American language that was used in these international documents to talk about the balance of civil liberties and public health protection. This gets us to the principle of proportionality, which comes up all the time when you're talking about the ethics of pandemics. And it comes up because it's one instance of this idea of the least restrictive means to achieve a goal. The idea here is a very simple one, actually. You know, you don't use a sledgehammer when a fly swatter will do. So the intervention must be proportional to what you're trying to achieve, and not too much in order to achieve what you need to achieve. But it also comes up in issues around resource allocation. In triage situations, the principle of proportionality means don't withhold resources from someone to save it for someone else unless you are really darn sure that that someone else is going to materialize, right? Because otherwise you may end up with someone who you triage away from receiving some resource, and then you never need to use that resource, and now you've harmed someone that you didn't need to harm. So in performing triage, you really need to know for sure that there are not additional resources available somewhere else. And you need to know for sure when your reinforcements are coming. You need to have excellent situational awareness, and you need to repeatedly assess people. And I have my favorite example of this is actually after Hurricane Katrina. So this is Louis Armstrong International Airport in New Orleans, right after Katrina. And you can see a lot of people on cots, very slow with the evacuation because things were damaged and so on. And there were a very large number of people actually who had black tags put on their toes, meaning they are triaged to receive comfort care only. They're expected to die. They're triaged to what's called expectant care. And very few of those people actually died. And the reason they didn't die is because they would continually go back to those people and re-triage them and say, oh, you know what? We thought that you were going to be expectant, but we're going to be able to get you out of here. Or we've got resources coming in that we're going to be able to give you treatment that we at first thought we would have to divert to someone else. So this principle of proportionality is critical, not only to the civil liberties area, it's also critical to the idea of resource allocation. So this is a second of these quiz questions, which again, I'm not going to put the quiz question up, but I'll just, or I'm not going to ask you to vote on this, but I'll just say that this is a very real question. So when it comes to resource allocation, if we were to have a big shortage of some resource, say hospital ventilators, which was the issue we had to grapple with back in March and April, when it really looked for a while there like we were on the upswing of cases to the place where we were going to have many more people who needed a ventilator than ventilators were available. And the question arose, should we as a state, for a state policy, should we say, if you're a doctor or a nurse or a frontline healthcare worker, should you get some preference if you get sick and you need to be put on a ventilator? And what our state, and for the most part, I'll tell you, people tend to vote the top two, and a few people, typically about 15–20% will say, no, they should be triaged just like everybody else. What they're reflecting on here is the principle of reciprocity, that people who sort of put their lives on the line, like veterans get lifelong medical care after their service, people who put their lives on the line may deserve a little bit of extra benefit if they get sick or injured while doing so. But of course, this is a very complicated issue, because there are a lot of people who were putting their lives on the line back then. Heck, there are people putting their lives on the line right now who continue to go to work, who continue to work in meatpacking plants, who continue to work in prisons, who continue to work in grocery stores, where not everyone is wearing a mask, right? So there are a lot of categories of people who maybe are doing things for their job that are putting them at some level of risk. And the question that we're continuing to grapple with, by the way, in our state protocols for resource allocation is, how do you address those folks who are at higher risk and whose communities are being devastated by this illness? Should we, for example, give a little extra boost in the triage protocols to try and give extra resources to these communities that are particularly hard hit? One of the things that I think people oversimplify in disasters, this has been a little less of a problem here because this disaster has spread out for so long, but in hurricanes, in tornadoes, in shipwrecks, one of the things that people sometimes say is, well, in a circumstance like that, you don't really think about anything else, you just think about saving the most lives. And that's an appealing simplification. Unfortunately, it doesn't actually work very well, Because for the one thing, we're not very good at detecting who's the most likely to survive and who's not. Even within hospitals where we have good medical record systems, we're not very good at detecting who's likely to die in the next 6 months or the next year. But the other question is, you immediately start thinking about, well, are we really talking about saving the most lives, or are we talking about saving the most life years? Because would you triage someone the same if they are, you know, a 15-year-old who has the rest of their life in front of them, or an 85-year-old, which, by the way, could be illegal to do that because that would be ageist. But I'll tell you, many people, when you get into conversations about this, will say, well, I just can't see how we could not make some differentiation based on age. That's a very common thing that people really have to walk their way through. And also, what if you have someone, you know, who has advanced pancreatic cancer? They have very low likelihood of being alive in a year. Would you still give them the same triage priority? And that, you know, this is a slippery slope, right? Because the next thing people say is, well, if you're going to count that, then how about looking at the most quality of life years, the most productive life years? And now you're getting very close to people saying, well, this life is worth more than this other life. And that leads people to say, well, what about old-fashioned principles like women and children first, which, by the way, reflect a real value, right? That reflects the value of continuing a good society in the wake of the disaster, which is something that we should care about. First come, first served also has some proponents, although not generally people who think they're going to be the last ones through the door because it's hard for them to get to the hospital. Ability to pay is actually how we do allocate resources in the American healthcare system quite a lot. Should that come into play when you're rationing care or services in a pandemic? And my point here is not that one principle is the be all and end all, but that there are a whole bunch of principles. And I'm not going to go through all of these, just to say that there are a variety of things that we actually have to balance when we're talking about developing guidance for, say, resource allocation in a pandemic. So, for example, in the Colorado state guidance, we actually say in the first couple of paragraphs, our aim is to provide the best care to as many people as we can, but to do so in ways that will preserve social cohesion, that will sustain some level of trust in the healthcare system, and that will allow our communities to come together and heal in the wake of the pandemic. So those are not pure utilitarian, reasons anymore. Now we're talking about things that go beyond just plain saving the most lives. So multiple values are important. We want to ensure continuation of a good society. We want to respect people who say, I don't need this, give it to someone else. We want to respect those who are dying. We want to protect more vulnerable, harder hit communities, and so on. So each of these needs to be balanced in the protocols that we come up with. And there isn't a single principle that's going to end up taking precedence in all cases. So last question that I'm going to ask you, maybe the most provocative one, because this has been proposed by a couple of people. Should people who are choosing not to wear masks today be denied use of a ventilator if they get sick and there's a shortage? And again, I'll tell you, because I've put this up to a number of classes, this is about 50-50. But I gotta say, this is the most difficult one for doctors, because we are trained and inculcated into a culture which says we do not punish people for their illness or how they got it. People do all kinds of dumb things. You know, they ride motorcycles without helmets. If I use myself as an example, they ski beyond their abilities and they end up hurting themselves. And we still treat them. So this would be a track that even though it's about 50-50 in the general public, people sort of say, well, look, if you chose not to wear a mask, you sort of deserve what's coming to you. That is not the tradition in medical ethics. We continue, and the terrific stories about this and instances of this. One, for example, after the Boston Marathon bombing, the Dzhokhar Tsarnaev, one of the bombers, was shot and was brought to the New England Deaconess Hospital, where I did my training. I was not there at the time, but the surgeons and the surgical team were interviewed by reporters afterwards. Like, how could you, just take care of him like he was, right after you had taken care of other people who'd been injured by him? How do you just turn around and take care of him? And they said, this is what we do. We take care of people who are injured and sick, and we can't spend our time thinking about whether they deserve to get injured or sick. That's not our job. There's a whole other system to implement justice. We are not part of the justice system in the medical care system. So let me go to this question of civil liberties and personal liberty, because I want to sort of close on questions around masking and quarantines and some of the civil liberties that we have, honestly, that we have given up in order to combat this pandemic. And it used to be said, this guy, Ron Bayer, really well-known public health ethicist back in the 90s, when we were dealing with the HIV pandemic, and it was sort of really at its peak at this point. And he said the ethos of public health and that of civil liberties are radically distinct. They were talking at the time about closing bathhouses in New York City, for example, to try and prevent, and that was an infringement on the liberties of people who frequented those bathhouses, but disease was being transmitted in the bathhouses. And so the sort of obvious thing was, well, let's close it down. The problem is attempts at restriction can actually backfire. So the reason the bathhouses were not always closed down was because people said, people are going to keep having sex. They're just not going to do it in a place where we know what they are and where we can actually get to them and encourage them to use protective measures. So I'll give you a couple of examples here. This is the report that I mentioned on public health evidence base for emergency preparedness and response. And I was on the committee that wrote this report, and we looked very carefully at quarantine. And it turns out that placing people in quarantine, if they don't understand and agree to it, can actually backfire. People can flee if they think you're going to be putting them into a quarantine. And if some of those people are sick, they may end up fleeing and spreading the disease out into the countryside. So there are several real world examples of this from the SARS epidemic in particular. So SARS was 2003, very dangerous virus related to the current coronavirus. And there was a rumor that all of Beijing was to be quarantined. And 245,000 migrant workers immediately fled the city, hoping not to be caught in the quarantine. Well, fortunately, they weren't sick. But had there been illness among those workers, they would have carried that illness out into the countryside. The same thing happened in Hong Kong, where the Amoy Gardens Apartments, which was the site of the first of the SARS cases in Hong Kong, was to be quarantined. The military were sent in to quarantine the apartment building, but when they got there, half of the apartments were completely empty. So people left. And by the way, I'll just say these, I don't want to be stereotypical here, but I think there is a stereotype that Asian countries are more compliant, that the communities there are more communitarian, that they believe what the government tells them and that they do whatever the government tells them to do. So these are communities that are, if anything, maybe more willing to listen to the government and what the government tells you to do. And it's been said in the US, everyone here has an SUV and a rifle. If you tried to quarantine Denver, I think, if people didn't understand and agree with that, they would leave. Same. By the way, when Wuhan was locked down, 5 million, it's a city of 11 million people. 5 million people were not there by the time they instituted the lockdown. And some of those people had left for other reasons. It was Chinese New Year, so it's not all entirely attributable to this, but still, a fair number of people left Wuhan in advance of the anticipated lockdown. So this raises this question of, can mandates like this backfire? Um, and I'm gonna talk for a moment about masks in closing here, but I don't want to I don't want to do that without first saying I am not saying masks don't work. Okay, so I'm going to talk a little bit about mandates, but but I am not going to talk about whether masks work or not. Masks clearly work. Okay, the question is, does a mask mandate work? And this is my image to talk about masks themselves. Many of you have probably seen this already. This was in Skagit, Washington, a choir practice where one person, no one was wearing a mask, one person came in and infected virtually everyone else in the choir during a choir practice. And by contrast, there were two hairstylists who, between the two of them, saw 140 clients while they were infected with COVID. But both the clients and the hairstylist, and by the way, with a hairstylist, you get pretty close, right? None of the 140 clients got infected. So masks are clearly effective. What I'm going to say is that if we want people to wear masks, we have to do more than just mandate it. Because unfortunately, masks have become this sort of political symbol, and they're a very visible symbol. And so if people don't understand why the mask is, that, you know, that masks are effective, if people don't understand why the guidance on masks changed, right? The very early guidance on masks from the CDC way back in March was, you don't need to wear a mask. Well, the reason that guidance came out was because we were worried that if the public tried to wear masks, there would be a run on masks and there wouldn't be enough for healthcare workers. But people got the impression that the CDC was saying, no need to wear a mask, they don't help. That wasn't known at the time, whether, you know, the extent to which they helped or not really wasn't known, but we didn't want there to be a run on masks. So the fact that that communication was not very clear at the outset is a big problem now, because now people look and say, oh, the CDC's, you know, flip-flopping on this. So anyways, this is a very nice piece by Angela Duckworth and Zeke Emanuel in the New York Times a few months ago about how to move people towards wearing masks without saying anything about mandates. So, so I'll end here with this question of sort of science communication in the public. This was a concern for the swine flu epidemic. It was a concern again after the smallpox vaccination program. In both instances, the CDC's advice, science-based advice, was ignored by the federal government above them, by the administration, for what was eventually seen to sort of be political purposes. This was a very nice report about the smallpox vaccination program put out by the Institute of Medicine in 2006, where they said the ability of the CDC was hindered by the administration because the administration at the time was very interested in people being frightened of smallpox. It was part of an effort to gin up support for the Iraq War. And the moment the war started, the smallpox vaccination program sort of disintegrated and was not followed up. Because it had served its purpose, and the CDC in the end was seen as having sort of been used. And the sad part about this was the bottom part of this quote from the report. The public health and healthcare communities started to feel like they were unable to trust the CDC for the information that it was putting out. And I have to say, this has now been a lesson we've clearly learned twice in the past, and I fear we are having to learn it again today. I put a paper that I wrote about this at the bottom here, but the quotes are not from my paper. The quotes are from the Institute of Medicine report. So I will end there and see if there are questions, comments. I've said a few provocative things, so I am hopeful that there will be a few questions and comments.
Well, fantastic. Thank you, Matt. That was That was great. And if folks want to do a little, virtual, we should do it a virtual was, right? We had several questions come in when folks were registering for this event, and I've kind of broken them up into four buckets: questions about science, about policy and communication, about ethics, and then some more speculative questions looking toward the future and the hopefully the post-COVID future that we will get to see soon.
We all hope for, yeah.
Right. But I think I want to start with this one, a question, because I think it relates really closely to part of your presentation about proportionality and resource allocation. This person asked, what is your opinion of the CDC's vaccine distribution guidelines? Do you think the method in which they prioritize certain groups was ethical?
Yeah, so we actually haven't seen the CDC's guidance yet. There are two groups that are working on this right now simultaneously: the Advisory Committee on Immunization Practices, which is a group of the CDC, and there's a group at the National Academy of Sciences, Engineering, and Medicine that was commissioned by NIH. So those groups, there is some overlap, and the people on those groups are definitely talking to each other. So I think in the end, we are going to see a coherent sort of package of guidance for this. And the groupings that have been put together look very similar, by the way, to the groupings, the sort of drafts that we've seen are looking very similar to what the questioner may be referring to, which is the influenza guidance. So there is old guidance for influenza in the event there's a pandemic influenza. And that guidance, put essentially healthcare workers and high-risk people in the first group. And then there are, tiers beyond that. And then, of course, there are multiple questions about that. Those are two very different rationales. Right? The reason you put healthcare workers in a top tier for receiving a vaccine is because they have high risk occupations. But gosh, other people have high risk occupations too. So, and you could make the argument that healthcare workers are even higher risk because they're taking care of people that we know are sick, and they're doing aerosol generating procedures on them. So I think there's a rationale there. But I'll tell you, not everyone in healthcare does aerosol generating procedures, and not everyone in healthcare takes care of people with COVID right now. So I think, you could stratify within healthcare workers those who are really top tier and those who are, at some tier below very top tier. And we would be prepared to do that if necessary. And then, of course, among the high risk individuals, the reason you're giving them the vaccine is because they may die if they catch this. They have a high risk of dying if they catch this. But I mean, even amongst high risk individuals, the risk of mortality, for people over 85 years old, for example, is about 15%. So that's not nothing. That's a very high risk of death. But that does mean that, 8 in 10 people who are over 80 and who get COVID actually survive it. So I think each of these are, you can create a rationale, and I think they're not unreasonable rationales. One of the rationales I'll just make note of is people often want to prioritize healthcare workers in part because of this reciprocity argument, but also because healthcare workers are taking care of other people. And so if you save one, maybe that person can get back in the fight and save additional people. That's been a very contentious issue around COVID, partly because COVID is a coronavirus. And when we saw the SARS virus back in 2003, there were case studies where healthcare workers who were put on a ventilator for SARS were not back at work for months. Most of them were not back at work for months. And so the question of, can you really get someone back in the fight so they can go back in and save other lives, which is a very traditional way of doing military triage, right? So military battlefield triage, you save the person who can get back into the fight and help win the war, right? So that was carried over into pandemic triage or epidemic triage. And it's not at all clear that that always works. Now, the counter to that, are those people really going to get back into the fight, is COVID has now been going on for 6 months and not really slowing. So, even if it takes 6 months, that healthcare person may be able to get back in the fight and save additional lives.
Great, and I think this is actually kind of a related question. Somebody asked, what are our responsibilities towards inmates in jails and prisons during the pandemic? And I think we could extend that just to ask about people living in total institutions, full stop.
Yeah, so very interesting. We're actually in post-production right now on an episode of our Hard Call podcast. So we do a podcast called Hard Call, and at the end of each episode, we ask people a question. What would you do if you were in this circumstance? And that's the hard call. And the one we're producing right now is on exactly this issue about a woman who is appealing to be released from prison. And we talk about justice and is it fair to have someone stay in an institutional setting when that institutional setting puts them at a higher risk of a potentially fatal illness? On the other hand, prisons are dangerous places to begin with. And COVID, yes, has made them somewhat dangerous, more dangerous, but not infinitely more dangerous. And one of the questions is, well, how good is the prison doing at trying to protect the inmates? And prisons have been quite variable at how well they've been able to do that. But you probably know there are very large programs underway. Maybe not large enough, but there are programs underway to try and reduce the populations in jails and in prisons. Jails have been much more successful at reducing their populations than prisons have. Prisons are just a Byzantine bureaucracy, and it's been much harder for a variety of reasons to get people for early release out of prisons, including for compassionate release for COVID.
Yeah. So this kind of picking up on a thread that that you raised right at the end of your presentation. Somebody asked, or notes, I'm concerned about the communication failures that have come to light during the pandemic, which are distinct from the incremental learning of the science community during this time. How do we avoid or correct communication failures that occur at a rapid pace while allowing for science to progress slowly over time as it is designed to do? Yeah, that kind of temporal miscalibration is hard right now, right?
It is, and I love that the questioner is flat out acknowledging, look, we did not know nearly as much about this virus in March as we know now. And we don't know as much today as we will know in 6 months. I guarantee you there'll be, new things that will come to light. The whole idea of, the use of ventilators has really transformed quite dramatically from the beginning of the pandemic until now. We're much more reluctant, actually, to put people on ventilators now than we were back in March, recognizing that may actually, unless it's absolutely necessary, it may actually make things worse. So we are learning as we go. And I think, there's no simple answer to that question except to, be honest, both about what your best evidence is right now and about the fact that we are continuing to learn. And I think one of the mistakes that was made, I alluded to earlier, is failing to sort of give the whole story in an attempt to make things simpler. And that is just always a balancing act, because you want to give people as much information, but not too much information to where it's overwhelming and panicking and people start to hyperventilate and do irrational things, right? If you give people information and because of the way human brains work, cognitive psychology, that they're gonna end up panic buying, well, there's a balance to be had there between being fully transparent and stoking panic or fear. So, you want to give information in a way that is most assimilable, that is most understandable, and least likely to prompt people to do things that are irrational and counterproductive, maybe not counterproductive for them, but counterproductive for everyone around them, right? And one of the things I like to emphasize, maybe this is a nice way to close, is there's sort of a belief in some populations, some groups, that people panic during disasters. And the consensus among social scientists is actually the opposite. During disasters, people do sometimes panic, but people tend to come together as a community and help each other more so than they do in non-disaster situations. And that's actually, what we actually see in most disasters is the community coming together as a whole to help each other. And so one of the things when I'm talking to public health professionals about this, I like to sort of emphasize is your job as a public health professional is sometimes going to be to pull the politicians back, because the politicians think, for understandable reasons, we have to be aggressive, we have to send the military in, we have to pass a law, right? We have to do things to show we are taking this seriously and being tough. And sometimes those things will end up backfiring. And sometimes those things will end up creating panic instead of resolving people's fears and anxieties. And sometimes you'll actually resolve the fears and anxieties by being honest about what you know and what you don't know and where the research is right now. And so, so I think as public health professionals, we often are in a position of talking about the principle of proportionality and preventing people from overreacting, because the public actually does not generally tend to overreact. The public tends to come together. But leaders sometimes overreact because they think the public demands it of them.
I wish my partner were here to hear you say that, because she works with emergency managers, and she has told me that numerous times, right?
Right. People who do emergencies know this.
They know. Yeah. Well, actually, I think this is a nice little segue into a question that has come from one of our attendees right now. Amy asks, what do you think of the medical community being completely managed under the federal government or completely independent of it? What are the potential risks of both situations?
Yeah. I mean, so number one, I don't think there is the real possibility of either of those extremes, right? The medical community is by its nature a quite independent group. Professions by their nature are organized around things that can't be fully controlled by the state or they go haywire. They also can't be fully in the free market or they go haywire, right? Because there are vulnerabilities among people that make them unable to shop around and be good consumers when they're, injured and sick. So professions tend to arise around work that needs to have some level of professional independence, both from the state and from the market. And so, that's my quick spiel on sort of professionalism and why teaching and ministry and engineering and medicine, these are all professions for a reason, because they have to sort of sit in this in-between space where they are influenced by the state. They're regulated often by the state, but we push back against those regulations if we think they're too ham-fisted, or we think they're too one-size-fits-all, if they're not, doing a good job of taking care of our patients. And similarly, we push back against, managed care plans in the free market who want to tell doctors how to do their job. So I think doctors by their nature, and nurse practitioners and pharmacists, all of us in the health professions have an interest in maintaining an appropriate balance between a state regulation to ensure consistency and quality and free market that allows for, that allows for people to sort of be entrepreneurial, as it were. And to be attuned to the needs of individual consumers, let's call them patients, right? So we want both. We want doctors who are attuned to the needs of individual patients and who are operating under a quality framework to ensure that they're not taking advantage of those individual patients who are in a very vulnerable position.
Great. This one, I think, is something that's on a lot of our minds, a lot of the folks in the room who are scientists and study science or on their way to becoming scientists. As a scientist, how would you respond to those who didn't believe the COVID-19 crisis was real or a big deal? How would you encourage them to care about it?
Yeah, you know, this really does get back to the whole question of risk communication. And people tend, you know, to underplay risks that they haven't seen themselves or that are being communicated to them from people they don't trust. And so when you're trying to talk to people about a risk that, you know, is a risk to their community, maybe not a risk, maybe not much of a risk to them individually. Although I will say, you know, we have lost a very large number of healthcare professionals to COVID who were 30 years old and, you know, mountain climbers. So it does happen. It's not an innocuous illness even for young people. But for many people, it is an innocuous illness, right? For many people, they get no symptoms. For many people, it's a sniffle. I will say, by the way, because this just happened last week, I climbed Quandary Peak 10 days ago. And at the top, bumped into a kid. I think he was 26. And he said, yeah, this is my first hike up a peak since I got COVID in March. And he had been, you know, very healthy, obviously, prior to COVID. And he had been laid low by it and had very severe lung illness that lasted for several months after the illness. So anyways, back to what I was saying. I think you need someone who can speak to people that they believe, and that means you know, finding people within the community who work in their local hospital, who, you know, minister at their church, who work in their you know, grocery store or barbershop. Those, you know, the barber may be a better communicator about why it's important to wear a mask. And the barber can put the sign up that says, I'm sorry, you know, it's not for you, it's for me. I'm not going to cut your hair if you don't have a mask on.
Yeah, as a social scientist myself, right? It's all of those Gemeinschaft connections, right?
Normalization,
right?
Yeah. It has to be expected, normalized, and understood. People need to understand why. And I think there is sort of there's a piece of the libertarian mindset which thinks this is paternalistic to tell everyone to wear a mask. That's actually not quite accurate. Paternalistic would be if we were telling you to wear a mask for your own good. We're not. We're telling you to wear a mask so you don't hurt other people. So it's the same reason why we have speed limits. It's the same reason why there are stop signs on streets, right? There's libertarianism. Even the original libertarian, John Stuart Mill, said you ought to limit people's freedom when they start hurting other people. And this, you know, this the old saying of my liberty to swing my fist ends just at the tip of your nose, right? So this is not about paternalism. This is about protecting others from people who, you know, may end up being dangerous and they don't know it yet.
Right, or as Hegel said, absolute freedom is terror.
Yes, yeah, anarchy, right. And I think, you know, I respect people who are libertarians. I have a harder time respecting anarchists who just think there should be no rules and that everyone should be able to hurt anyone they want. That you know, which, by the way, is also a simplification of anarchism. But
well, actually, this sort of touches upon questions of the economy and stuff, but another kind of pragmatic question that popped up was, had we not shut down the economy, but instead taken precautions with mask wearing and avoidance of large gatherings, what do you think would have happened with the virus? I guess, you know, a question that I see a lot in the media certainly is, was
Yeah.
it necessary to take the drastic steps to shut down businesses and everything?
Yeah. Well, I mean, so had we followed through after the shutdown, had we fully shut down, including in states that didn't shut down, and had we followed through on the shutdown, we would look closer to Australia or Germany. And, you know, we would probably have much more open economies right now and many, many fewer deaths. Right. I think if you look at Hong Kong and New York City had their first case on almost the same day. Hong Kong, of course, is much closer to China, so they were destined to have more cases, probably, than New York City was. But as of last week, Hong Kong had had 99 deaths from COVID, 99. New York City, bigger city, but you know, comparable size, more than 30,000 deaths. So many of those were not necessary had we been able to manage this in, you know, in a way that really tamped down on spread. On the other hand, if you look at some, you know, countries in Europe, Switzerland, for example, is the famous example because they essentially said, we're not going to close everything down. We're going to more or less let people just make their own independent judgments about whether they feel safe and comfortable going out to restaurants and so on. They've had higher mortality than we have on a per capita basis, and they've had a terrible economic devastation. So unfortunately, you know, we're just going to let it burn and rip through the community, that also didn't work. So I think, you know, what we really need to just sort of manage this the way we know how to manage pandemics. It's not like there wasn't a playbook for how to manage pandemics. There is literally a playbook in hard copy for what to do during a pandemic, how to communicate, right? Where to put your resources, how to use the Defense Production Act to ensure that you've got enough masks and gowns and visors, and right there, we knew how to do this, but it sort of fell prey to it became politicized, which is just tragic. It's just really tragic that it became very politicized very quickly. And as a consequence, you know, I honestly thought in February, when I first started getting wind that this was going to be a big deal, I honestly assumed, and I'm getting into political punditry now, but I assumed this meant Trump would be reelected. I thought, you know, this is like 9/11. It's a war. The country is going to come together, rally around the leadership. That's what we do during wars. We come around, we rally around the leadership. So I looked at this and thought, this is a guarantee win in terms of the politics of it for whoever's in the Oval Office at the time. And yet somehow it has become so divisive that that's very much in question now.
Yeah, and related back to what we were just saying about, you know, libertarianism and that kind of, you know, orientation to public life. Someone asked, do you see the COVID-19 pandemic presenting an opportunity for any fundamental ethical questioning of the American ideology of individualism?
Yeah. Well, I think, so first of all, I think this pandemic is, you know, it's the real deal. It's not the worst pandemic you can imagine, right? You could easily imagine a pandemic where the mortality was 2 or 3 or 4 or 5%, which would have been, you know, even much more devastating. But this is as big a deal for society as, you know, World War II, which is saying a lot. At least since World War II, I don't think there's anything comparable in terms of worldwide impact, which means there will be dissertations written about this for generations. There will be lessons and, you know, learned and unlearned and relearned and reinforced and lost for generations. And I think there is no doubt, I don't know what the impact will be on how we think about each other as Americans, and as a community, and, shared values, and our, sort of, there's always been a tension in the US of libertarian and communitarian, right? So the Lone Ranger is part of us, but so is barn raising, right? So is coming together as a community to help each other out. So we've always had within us this, rugged individualism on the one hand, and we care about our neighbors on the other hand. And we've tried to blend those, and that blend will continue. That's my general sense, is that this won't fundamentally alter that dynamic, because that dynamic has been with us since the very beginning. It's a very baked in part of our culture that we have these competing ideals of rugged individualism and community at the same time. And most of us hold those ideals within ourselves, right? Most of us are not one direction or the other. So, I think this is to some extent just, part of human nature, which I'm just totally dancing around this question, because I don't know how this is going to affect how we think about ourselves. And I think it could very well depend on how things play out over the next year, right? If we do all sort of end up 6 months or a year from now feeling like, wow, we really beat that thing, and we did it because everyone agreed with the vaccine distribution scheme, and it was put together in a way that really, brought the public into the dialogue, and was, everyone bought in. I could imagine this having a really salutary effect in terms of community cohesion.
Yeah.
But I could also see the other.
Memories are short nowadays too, right? Well, since we're in the realm of speculation, well, actually, no. Before
most of what I do is that. So,
but actually, before we jump fully into the realm of speculation, somebody asked about the second wave. Are we in a second wave? Is the second wave happening? What do you make of the talk of second wave?
Yeah. It's not a great metaphor, unfortunately, unless you're really talking about a tsunami, right? So maybe not everyone knows this, but a tsunami is not a single wave, right? A tsunami is a whole bunch of waves that happen like this. So it can be an enormous first wave, but then there are continuing waves, which is what makes it so deadly. So we are going to have, so pick your metaphor. We're going to have brush fires, or we're going to have waves, or we're going to have outbreaks, or we're going to have clusters. I think the language of the day right now is clusters, which I think is lovely because it reminds me of like a peanut cluster. It sounds like a dessert. And I'm pretty sure that's why people like that language, because it sounds not so bad, a cluster. But that is what's going to happen, right? We are going to continue to see outbreaks here and there. And those outbreaks will force those communities to have to clamp down again in order to tamp down the outbreak, if they are not in a position where they have very low levels of transmission to begin with, and they can find the outbreak before it jumps the trees. I think forest fires are probably a better analogy here, because there will be embers, right? There's a big cluster in South Dakota. Well, that cluster in South Dakota is going to end up sparking into North Dakota and into Colorado and into Wyoming. And there are going to be clusters there. And the question then becomes, can those local public health departments, are they resourced such that they can do the testing necessary to find people before they get very symptomatic, to do the contact tracing, to find all the people that they've interacted with? Are all those people willing to stay home for 2 weeks? Right? That's what needs to happen. We need to have low enough levels of transmission that we can find every person who gets infected and all the people they've contacted in the last 6 days, and ask them all to stay home, and they're all capable and willing to do that, right? And that means they have to get a hotel room if necessary. We have to pay for their hotel room. We probably have to pay for their food sometimes. If they're a homeless person, we're going to have to put them up, right? Because otherwise that cluster is just going to turn into a little conflagration or a big conflagration. So there's money involved, but if you do it right, it costs much less, right? It costs money, but it costs much less to get people to isolate and support them in their isolation than it does to have people with the illness out walking around, and going to work, right? Which is usually what people have to do, right? If we're not going to support people in isolation, they're going to have to go to work because they'll starve otherwise.
Right. Okay. So I'm being told we need to wrap up. So I have one final kind of speculative question, and this comes from someone who registered beforehand. Like, what practices taken during the pandemic do you think will remain after herd immunity is reached, or after where I don't know whether that's the end point here, but are there things that we're doing now that you think will become part of our kind of daily routine?
Well, I mean, what the conventional answer to that question in healthcare is telemedicine, right? We are not going to go back on telemedicine because too many patients and too many doctors have realized how very convenient it is to just sit at your computer and have a visit with your doctor. And I think there's a lot of other tele stuff, right, that has happened. I was on another call earlier today where we're planning a lecture series that was normally done in person. And this year, of course, we're doing the lecture series online, and we'll record it and we'll post it. And I can't imagine going back to the time when we did a lecture and we didn't record it and post it for people and allow people to Zoom in if they want to, instead of coming to the lecture hall. It dramatically has increased the number of people seeing the lectures that we do. We've had lectures that would have normally drawn 70 or 80 people, and we get 400 because people can Zoom in from all over the country. And you just have to put out a notice saying, we're doing this lecture, you might enjoy it, and people end up signing on, or they watch it later, right? So I think there's a lot of tele stuff that will absolutely carry on beyond this. The other things that I foresee potentially carrying on, and this gets actually to the last question a little bit, prior to the pandemic, there's a database that all the hospitals in the state are supposed to use to track how many ventilators we have and who's on a ventilator, and sort of so that we know in case there's a big demand all of a sudden. Prior to the pandemic, that database was almost never filled. It was like 5%, 12%. Very few people were submitting their data. And now it's completely like 99%. It is accurate. We know everyone, all these competing healthcare systems that used to not talk to each other and think they had like trade secrets and stuff. Their chief medical officers have been meeting together, weekly, or I think it's monthly now, but it was daily for a while. And those are relationships, right? Those are going to stay. And hopefully some things have been learned about how to work together as a state, how to work together as a group of healthcare systems, and not just as competing healthcare entities, right? So I think there will be things that come out of that. I don't know exactly what they are right now, whether it's, purchasing alliances or better planning for the next disaster, or just better relationships across, better, more trusting relationships across systems that are inherently in competition with each other, but also need to be able to pull together and work together in a catastrophic disaster like this.
Well, thank you very much. Sandy, do you want to?
I don't know. I just think it's so awesome. I guess I should say thank you again, and thank you for letting us record this. So I guess we're going to be recording everything. And yeah, I guess that's really it. I really, really appreciate you coming to talk to us yet again.
My pleasure.
And I'll probably bother you again because that's how I am. But I do hope that you and yours are well. And
Thank you.
We'll see
Thank
you
you
again
very
someday,
much.
I hope.
All right. Take care, everyone.
Thanks, Matt.
Have a good evening.
Okay. You too. Bye-bye.